Good morning, everybody. Welcome to our March Grand Rounds. I'm going to start with some thank yous to the residents. And the first one is for Jake Wilkerson. And this is from Dr. Graham Nichols, who is a Harborview ED attending. And his compliment states that Dr. Wilkerson is doing a great job of taking care of patients in the ED and maintaining a collegial atmosphere with our ED colleagues. So thank you, Jake. I assume you are watching from Harborview. Second one is for Dr. Zach Walterscheid, and it's from Dr. Vetter. And Dr. Vetter says, Zach is a superstar orthopedic R1, perhaps the best I've ever worked with. Super smart, outstanding fund of knowledge, excellent patient care, and really good hands. And he goes on to compare him to Mary Kate Thayer. Wow. And Dr. Vetter states he has a fabulous personality. It'll be fun to watch him develop as a resident. Thank you, Dr. Walterscheid. And the last one is for Jackie Donahoe, and this is a nice one. It's from a mother of a patient of Dr. Kringle's. And this patient's mom said that Dr. Donahoe went out of her way, the mom went out of her way to say that they had a fantastic experience with Dr. Donahoe. She was just wonderful, exclamation point. So thank you, Jackie. This morning, we are going to have Dr. Brett Schiffman, who's a PGY4, and Dr. Iannuzzi, who you all know is an assistant professor in our department. Dr. Iannuzzi is based at the VA, but he is a jack of all trades and practices at Harborview and also at UW Medical Center. And their talk is going to be on the past, present, and future of Dupuytren's disease.
Yep. Go. All right. Good morning. I'm Brett Schiffman. I'm a orthopedic surgery resident at the University of Washington. And today, along with Dr. Iannuzzi, I'll be presenting grand rounds titled Dupuytren's Disease, Past, Present, and Future. And we have no disclosures. So today's talk will be broken into two sections. First, I'll be talking about the background of Dupuytren's disease as well as the history, followed by Dr. Iannuzzi talking about contemporary treatments. Dupuytren's disease is a benign fibromatosis of the palmar and digital fascia of the hand. The spectrum of disease may range from mild thickening of the palmar skin in the form of a painless nodule to a complex web of cords resulting in flexion contractures of the fingers, loss of finger dexterity, and function of the hand. Dupuytren's disease is thought to be a relatively new disease. While it's known as the Viking disease, there are no writings in the early Gaelic medical literature, nor in the writings of the ancient Greeks or Romans describing palmar hand contractures. It was first described by Felix Plater of Basel in 1614 in a case involving a stonemason with ulnar finger contractures that progressed despite splinting. He theorized that due to the repetitive trauma from his occupation, he developed flexion contractures as flexor tendons pulled from their sheaths and contracted. Plater, along with many others, felt that the pathologic palmar contractures, eventually known as Dupuytren's cords, were secondary to flexor tendon pathology rather than an abnormality in the palmar fascia. This was a misconception that would persist for many years. Henry Klein, a surgeon in London, was the first to recognize the role of the palmar aponeurosis in Dupuytren's disease. In 1777, the same year as the birth of Guillaume Dupuytren, for whom the disease is named, Klein dissected two cadaveric specimens with palmar contractures of the ulnar fingers. He found normal muscles and tendons in the presence of thickened fibrous cords within the fascia that, when cut, allowed the fingers to be extended, thereby performing the first surgical treatment for Dupuytren's disease, a palmar fasciotomy. Dupuytren was a French surgeon in Paris who is credited with first distinguishing between congenital dislocation of the hip and acquired dislocation, providing the original description of distal fibula fractures and Madelung deformity, as well as performing the first lower jaw resection and hysterectomy for uterine cancer. He described permanent contractures of the fingers in a lecture in 1831 in which he discussed his experience with 30 to 40 patients over his career. He had initially thought that the pathology was secondary to flexor tendon contractures, as did Plater. However, after dissecting the hand of a deceased patient with ulnar palmar contractures, he found that there were scarred contractures of the palmar fascia extending from the palmar aponeurosis. He found the flexor tendon sheaths, tendons, and joint surfaces were unaffected. Later that year, he performed his first open fasciotomy. Although the patient did go on to develop a wound infection, he regained the ability to extend his fingers fully and had function of his flexor tendons, further supporting the theory that the palmar fascia was the origin of Dupuytren's contractures. Jean-Gaspard Goiran trained with Dr. Dupuytren and went on to conduct his own research on palmar contractures. His findings caused a paradigm shift in the etiology of disease, as the etiology being hereditary rather than of occupational. In the 1950s, with the development of hand surgery as a subspecialty, Sir Archibald McIndoe began treating Dupuytren's disease with extensive palmar fasciectomy by transverse palmar incision with excision of digital lesions via Z-plasties. These procedures involved significant undermining of skin flaps and as a result had high complication rates, which included hematoma and skin necrosis. There was a shift by surgeons in the 1960s to perform limited fasciectomy with digital palmar approaches. The overall global prevalence of Dupuytren's disease in today's Caucasian population is between 3 to 6%. Global distribution of the disease supports the theory of northern origin of Dupuytren's disease with dissemination by the Vikings during their conquests. The Vikings completed expeditions to Canada as well as Central and Western Europe. These are all regions of the world that have higher prevalence of Dupuytren's contractures historically. Interestingly, there are reports of sporadic cases in communities that were not known to have been explored by the Vikings, including Africa and India. Prevalence is generally low throughout Asia, except for Japan, which has a prevalence of 16 to 28% in males and 3 to 10% in females. The familial nature of Dupuytren's disease was described as early as 1833. The genetic basis of disease etiology is the subject of current investigation, with the present understanding that Dupuytren's disease represents a polygenic, autosomal dominant trait with incomplete penetrance. Family history has been reported in the literature in as high as 68% of patients surveyed. Hindocha et al. Performed a study in 2006 looking at 92 patients treated surgically for Dupuytren's disease. They found a high percentage of positive family history in their patient population, with 41% reporting a family member suffering from Dupuytren's contracture. They also found earlier onset and more severe disease in patients reporting a positive family history compared with those without. Sibling recurrence risk ratio was found to be 2.9, which indicates a high degree of familial aggregation and suggests a high genetic basis for causation of disease. While there's been shown to be a strong genetic component of Dupuytren's disease, there's more contributing to disease manifestation than solely genetic expression. There's thought to be a genetic predisposition to disease with a poorly understood environmental component that triggers disease. This is demonstrated by the relatively late onset of disease in non-familial cases, suggesting that many years of cumulative environmental exposures lead to cord development as genetically susceptible individuals age. Lial reported on 2 pairs of monozygotic twins with similar risk factors for disease. Despite their identical genetic material, only one of each of the pairs went on to develop Dupuytren's disease. Epidemiologic studies have also demonstrated a relationship between age and Dupuytren's disease. Onset's typically associated with adult life with a mean age onset of 49 years old and an increased prevalence with age. While Dupuytren's disease in younger patients is less common, cases have been reported in patients as young as 6 years old by Dupuytren himself, and there are also cases, rarely, of adolescents or infants developing disease. Symptom onset before the age of 30 is typically associated with a more aggressive course and early and severe contractures compared with those with symptom onset at 60 or later. There's also been a reported high risk of recurrence of contractures after operative management in patients with earlier onset of disease. There's variation between genders, with men having earlier onset than women, who have a mean age of onset between 60 to 70 years old. Women tend to have more gradual progression, and as women age, the prevalence in women approaches that of men. The literature has reported mixed results regarding risk factors for Dupuytren's disease. There have been reports of trauma, occupation, alcohol consumption, liver disease, smoking, hyperlipidemia, diabetes, anti-epileptic medications, or HIV status being associated with a higher prevalence, although there are studies that refute these risk factors as well. Rheumatoid arthritis is the only known protective risk factor associated with a decreased prevalence of disease. Individual digits are affected at differing rates, with contractures most frequently involving the ring and the small finger. The index and the thumb are much less frequently involved, and the table below lists 4 large studies looking at individual ray involvement. While there's some variation amongst the studies, there's a clear trend that the only 2 most digits have higher involvement. There's disagreement as to the degree of involvement of the thumb depending on whether the first web space is included in the study. While involvement of the thumb ray itself is rare, cord involvement of the first web space is relatively more common, and reports have been as high as 63% prevalence. Typically, the disease will start in 1 ray and progress to 1 or more rays as symptoms worsen. In 1963, Houston published his results on 159 patients treated surgically for Dupuytren's contractures, for whom he followed 3 years postoperatively. Of the 159 patients, 48 went on to have recurrence of contractures. Patients with recurrence were younger, twice as likely to have a positive family history, 3.5 more times more likely to have knuckle pads, and bilateral disease or planar lesions. Using his results, he coined the term Dupuytren's diathesis, indicating that there were characteristics which may indicate more aggressive disease course with higher risk of recurrence. The original diathesis included palmar lesions, family history, ectopic lesions, and Northern European ethnicity. Hindocha in 2006 published a modified criteria which took into account gender and age. Using the modified criteria, it was found that 71% of patients with all modified factors went on to develop recurrence, compared with 23% when 1 factor was present. In 1959, Luck described the progression of Dupuytren's disease in 3 stages. He studied the excised cords of nodules from over 200 hands and 28 feet and identified 3 distinct histologic stages of development, which he termed the proliferative, involutional, and residual stages. The proliferative stage includes nodule development, which histologically is a focus of fibroblasts, which resemble a fibroma. At this stage, the nodule is largely cellular without much collagen. The fibroblasts are not organized along lines of stress, and the nodules tend to be supple. They may be solitary or multiple. Initially, the nodule grows within or on the superficial border of the palmar fascia, and as it grows into the subcutaneous tissue, it may displace the subcutaneous fat and become more easily palpable. The nodule grows and forms attachments to the skin. They may develop in the palm, first web space, or fingers, but are rarely seen distal to the PIP joint. During the involutional phase, fibroblasts continue to upregulate and align along the axis of tension that passes through the nodules. There's a transformation of fibroblasts to myofibroblasts and deposition of type 3 collagen. Myofibroblasts contract, pulling tension on the collagen fibers as collagenase acts to break cellular bonds, which are reformed in new shortened positions, resulting in tethering of tissues and joint contractures. As the cords grow and contract, the nodules decrease in size and draw in the skin, causing puckering. The rate of progression of involution and thereby contracture development is variable and unpredictable. As the involutional stage progresses, the nodule decreases in size and is less defined. Cords become the dominant pathologic structures. The location and nature of the cord determines the type and the severity of the contractures the patient experiences. As the disease process transitions into the residual phase, the nodule has regressed and cords are largely made up of collagen, with histology that's predominantly acellular with few myofibroblasts. Long-standing joint contractures can lead to degeneration of articular cartilage, joint capsule contracture, and atrophy of surrounding unaffected palmar fascia and skin. On a biochemical level, there are multiple signaling pathways that can be extrinsically triggered in a genetically susceptible individual. Researchers have identified growth factors activated by IL-1 that lead to fibroblast differentiation, to myofibroblasts, and collagen production. We've yet to utilize this biochemical pathway to intervene. However, hope for the future is to be able to alter this biochemical pathway to prevent the pathologic transformation of cells that leads to Dupuytren disease. The palmar fascia is a normal anatomic structure made up of individual named components. It's a 3-dimensional system of fibrous structures that extend longitudinally, transversely, and vertically to anchor the palmar skin to its underlying structure. The fascia thereby performs a vital function that contributes to the profound dexterity of the hand and digits, without which prehension would not be possible. This differentiates the palmar skin from the dorsal skin of the hand, which lacks an anchor to the underlying structure, and thereby is more lax and would provide a less functional grasp. The palmar fascia provides a three-dimensional scaffold that, in addition to stabilizing the volar glabrous skin, compartmentalizes the hand. This helps to protect the neurovascular structures of the hand as they branch into smaller structures extending into the fingers. Similarly, within the digit, the fascia functions to anchor volar skin to the bony architecture of the finger and compartmentalizes the space separating the neurovascular structures from the tendons, phalanges, and joint surfaces. Pathologic changes manifest first as nodules, which occur between the skin and the superficial fascia. Pits may occur as superficial fibers of the pretendinous band and vertical bands of Grappow, which insert into the skin, contract, and draw the skin down. As additional normal fascial structures are involved and remodel in a contracted abnormal fashion, they are then referred to as pathologic cords rather than normal bands. Contractures typically begin with thickening of the pretendinous band into pretendinous cord over the ring finger ray. There may be involvement of natatory ligaments, which thicken and contract, resulting in finger abduction limitation and finger contractures. As fascial bands pathologically become cords, the location of the particular fascial structure affected determines the nature of the contracture and which joint or joints are affected. When multiple structures are involved, a complex contracture can result, involving multiple joints and web spaces. Presence of a spiral cord can result in MCP and PIP flexion contractures, as well as displacement of the neurovascular bundle. Physical examination of Dupuytren's disease consists of assessing and characterizing pathologic structures, as well as obtaining information relevant to treatment. Initially, inspection is performed to identify nodules and cords that may contribute to hand dysfunction. When assessing flexion contractures, it's important to assess each joint in isolation with a digital goniometer. Dynamic contractures may exist when cords involve multiple consecutive joints, resulting in motion that's dependent on neighboring joint position. For this reason, it's important to measure PIP joint when the MCP joint is extended as well as flexed. The tabletop test is a commonly used reproducible test in which the patient attempts to put their hand flat on the table with the palm directed down. Test is positive when a patient is unable to simultaneously place their palm and fingers flat on the table. The dorsal hand should also be inspected for ectopic nodules, and neurovascular status should be assessed with digital Allen test and two-point discrimination. In 1982, Watson published a study describing a method to identify a spiral nerve. This is a term he coined to describe the displaced neurovascular bundle caused by a spiral cord. This is important for the surgical planning, as preoperative identification of a spiral cord can help the surgeon to avoid iatrogenic injury to the neurovascular bundle, which may be displaced from its normal anatomic location to a more medial and superficial location. Watson found that a spiral nerve could be predicted preoperatively by the presence of a soft, pulpy mass of skin measuring approximately 2 centimeters in diameter, which lies between the distal palmar confluence and the proximal finger crease. In a retrospective study of 276 consecutive patients treated surgically, 44 had intraoperative findings of a spiral nerve. 90% of these 44 patients with a spiral nerve were found to have redundant pulpy skin lesion between the palmar crease and the proximal finger crease, with a 4% false positive rate. With that said, we will transition to Dr. Iannuzzi, who will continue to discuss the treatment of Dupuytren's disease.
Well, first of all, I wanted to thank you guys for letting me come and talk here today about something that I kind of enjoy seeing and treating, and that's Dupuytren's disease. And I wanted to thank Dr. Schiffman. That was a kind of great introduction and review regarding some of the historical, epidemiological, and pathophysiological aspects of Dupuytren's disease, and certainly a lot of information to cover, so thanks, and great job. So I'd like to continue this discussion by touching briefly on classification systems for Dupuytren's disease. Mainly, how do we discuss this condition succinctly? And then we can review the natural history, treatment options, and how I generally deal with postoperative care. And then lastly, we'll get into kind of a discussion of what the future may hold for Dupuytren's research with respect to patient outcomes. So patients often want to know, how bad is it? And as you can see, there are multiple different classification systems for Dupuytren's disease. But I'd argue that few of these systems are commonly used, even among hand surgeons. And when they are used, the most common context is probably research. Of these classification systems, the Tubiana system is probably the most commonly used. And this system's undergone a few modifications since its introduction in the late 1960s. But in general, it's followed the same basic structure. Each digit is provided a stage based on the total flexion contracture present. And the presence of a cord in the palm is designated by a P. The presence of a cord within the digit is designated by a D. Nodules are given designation of N. And in the end, each hand can be presented in what looks like a mathematical equation, and it just gets pretty complicated. So the hand you see here has a total flexion contracture of 55 degrees at the middle finger with a palmar and digital cord. And Tubiana would classify this hand, this right hand, which is MD, as 0 PD for the thumb, 0 for the index finger, 2 PD for the middle finger, NP for the ring finger, which has a nodule, and 0 for the small finger, and with a total value of 2.5. And I'd say that even most hand surgeons probably wouldn't be able to tell you what this means if they were to hear it over the phone. And so you could contrast this with simply describing the hand as having a middle finger with a 30-degree MCP joint contracture, a 25-degree PIP joint contracture with a pretendinous cord, and ring finger nodules. And I think everybody gets an idea of what that hand looks like. And so while the Tubiana classification system is something to be aware of, and it's played a role in research, I'd say practically it's not something we use every day, and it's just helpful to kind of have that in the back of your head. What patients also want to know is how bad is it going to get? And why don't we just operate on everybody that comes in the door when they have a nodule or a simple cord? And basically, there's a few good reasons, and we'll go over a few of them today, but it's important to understand that not all nodules or cords are going to progress, that with enough time after surgery for contractures, they may recur, and revision surgery is hard. If we operate on these lesser contractures and nodules early and then there's a recurrence, we're going to be in for a much more difficult and potentially dangerous surgery later on. So if we look at the natural history of Dupuytrens, we don't have a ton of data, but the data that we do have seems to suggest that not all cords and nodules develop into contractures. Malaysi looked at 150 hands with either a nodule or a cord and noted only about 2 out of 5 developed a contracture at 3 to 5 years, and still less than half developed a contracture between 6 and 12 years after initial presentation. He didn't note the severity of the contracture in these patients, so it's hard to draw very firm conclusions, but the progression of disease wasn't a certainty in his patients. He also looked later at 113 patients with contractures on one side and an asymptomatic hand on the other, and noted that less than half developed contractures in the asymptomatic hand 6 years after presentation. And then lastly, Riley et al. Looked at patients that presented with a simple nodule and noted that about half developed cords at 9 years after presentation, and again, fewer than 1 in 10 will develop a contracture of 30 degrees or greater at the MCP joint or any contracture at the PIP joint. So it's comforting for patients to understand that the presence of the condition doesn't necessarily mean that they'll assuredly progress towards a contracture. So overall, when a patient presents with nodules, the treatment for me is mainly observation. There are a few indications in which more aggressive management may be offered. Patients sometimes complain of pain, but if there's underlying conditions that a patient would like addressed, maybe a trigger finger, a retinacular cyst, or if there's some uncertainty regarding the diagnosis, then removing a nodule may be considered at the same time of dealing with other disease. But in general, the diagnosis of Dupuytren's is largely clinical, and a biopsy is certainly not required for diagnosis. So again, for the majority of these patients, I'll just observe the patient and monitor for changes. For patients that are kind of unsatisfied with that option of observation alone, or with particularly painful nodules, we can discuss steroid injection, but I'll be very clear about kind of what exists in terms of the literature for steroid injections. And in general, I'd say I've had pretty few takers with this respect. Probably the best study to date for steroid injections is by Kitchum in 2000. And he described his results after an injection in 75 hands in 63 patients. So I think it's important to look at his methods and how he did it. He used a very high dose of steroids, 80 to 120 milligrams of triamcinolone, which is quite a lot for a simple nodule. And on average, patients required about 3 injections. He described 60 to 80% of regression in the nodule in most of his patients, but that wasn't an objective measure. That was based on his observations. And then he noted a pretty high rate of recurrence, 50% of patients at 1 to 3 years. There are other forms of treatment that are discussed in the literature. For those of you that are interested, Catherine Ball out of the UK has performed a systematic review of the data available for these treatments. But there's just very little strong evidence for radiation therapy, steroids, vitamin E, hyperbaric oxygen, or aminosine. And I'd say radiation is one that I do get asked about occasionally, and I think it's just nice to look at it. Most of the treatment studies for radiation occur in Europe, but the studies are fairly limited. They're all case series, there's no control groups. The dose of radiation, the timing of these doses vary, and the outcomes used are often relatively vague. So the largest study I was able to find was that by Epidemiology, and he evaluated 176 patients at an average of 10 years using the to be honest stage as an outcome. He noted the disease remained stable in the majority of patients with early disease, and then it worsened in the majority of patients with more severe disease, which probably doesn't vary much from what we've seen in kind of the natural history of Dupuytrens. So we do have some criteria when we kind of intervene as surgeons, and in general, these are the criteria that I use: contracture of at least 30 degrees at the MCP joint, or 20 degrees at the PIP joint. And there's some exceptions to these numbers. If the patient has well-defined functional limitations, I would consider operating earlier. But I think these are just a reasonable general guide. And then if patients are having trouble conceptualizing that, I'll kind of refer them back to that Houston tabletop test and say, if you can't put your hand flat on the table, definitely want you to come in and we can take a look at things. So getting on to treatment for cords and contractures, we're going to talk about 3 main forms of management. And these are the percutaneous needle aponeurotomy or fasciotomy, Collagenase, which is known by the trade name Xiaflex, and limited fasciectomy. And I'd say that these are probably the most common treatments for what I'd call primary or straightforward Dupuytren's disease. And we just won't get into kind of more severe recurrent Dupuytren's disease today. That might take a little bit longer. But I will say that there are ways to treat these severe contractures or recurrent disease, and that may involve staging the procedure, performing a joint fusion or arthrodesis. And really, the topic of amputation should be discussed. This can be a complication of initial treatments for Dupuytren's disease, or an acceptable form of management for the disease in some patients with severe contractures. So the first option, percutaneous needle aponeurotomy or fasciotomy, that's generally an office procedure. I'll perform this using local anesthesia in the office. Generally, a 25-gauge needle can be used to perforate the cord, either using short piercing motions or gentle sweeping motions. And in the presence of pits or tethered skin, the needle can be used superficially and tangentially to the skin to free the cord from the skin in order to try and prevent skin tears. I'll generally start proximally and work distally, and usually reserve this management for pretendinous palmar cords and avoid injuring the nerves in more digital cords and contractures. The results are fairly favorable. PES, a surgeon out of New Jersey, is probably the largest series of patients, and demonstrated good results in over 1,000 digits. He's able to achieve 0 to 5 degrees of residual contracture at 6 weeks in 98% of his MCP joints and 2/3 of his PIP joints. He did note a relatively high recurrence rate at 3 years. And while 75% maintained at least 50% of their improvement at the MCP joint, only about 1/3 maintained that same improvement at the PIP joint. So it's important to note also that he had a relatively low rate of complications, and he didn't stop anticoagulation in these patients. He also noted that patients older than 55 years generally had a lower recurrence rate than younger patients. That procedure, percutaneous needle fasciotomy, is relatively cost effective. So if you perform it in the office, It's certainly cheaper than fasciectomy in terms of cost per quality life year, and it's cheaper than the cost of collagenase management, assuming you don't get that medication for free. So in general, when I think about percutaneous needle aponeurotomy or fasciotomy, my ideal patient is older and often medically complex. They're patients that might be poor surgical candidates due to various comorbidities. And for these patients, I can provide a relatively good result. The procedure also requires few resources and it's relatively safe. And there are some studies that have discussed kind of the adjunctive use of steroids in these patients, but the results of that are relatively inconsistent, and I generally avoid the addition of steroids there. So collagenase is kind of the second form of treatment we'll discuss today, and it can be a little bit difficult to conceptualize, so I generally discuss with patients that you can think of kind of that Dupuytren's cord as a rope of tissue. And this enzyme that we're going to inject under the skin is going to dissolve that rope. It's going to turn that rope into a frayed rope with a bunch of weak areas. And then when they come back in a day or a week, we're going to basically extend the finger and break that weakened rope to try and resolve their contracture. So the medication comes in one vial that has to be mixed with a sterile diluent. There's different concentrations for the PIP joint and the MCP joint. And generally when I perform this, I'll provide local anesthesia at each visit, perform the injection of collagenase at one visit, and have the patient return for manipulation between 1 and 7 days after the initial injection. The results, again, are fairly favorable, particularly for the MCP joint. The cordless trial by Paymer et al. Demonstrated an improvement to 0 to 5 degrees in 72% of their MCP joints and a little more than half of their PIP joints. But about 40% of the MCP joints and 2/3 of the PIP joints experienced recurrence of a contracture of at least 20 degrees at 5 years. Hurst and Badalamenti, who were integral into the formulation and development of collagenase, also noted some difficulty treating PIP joint contractures using collagenase, with only 34%, or about a third of PIP contractures greater than 20 degrees reaching straight or 0 to 5 degrees after up to 3 injections. And the results for those patients were particularly worse if they had initial contractures of greater than 40 degrees of the PIP joint. Complications aren't uncommon with collagenase. Patients may experience pain, bruising, swelling, and sometimes all the way up to the shoulder, the axilla, and so I'd have a thorough discussion with patients about that. Skin tears associated with manipulation also occur with some frequency, and these tears are generally treated with simple wound care, meaning soap and water and daily dressing changes, but they're certainly disconcerting for the patient. Luckily, more significant complications such as tendon rupture, nerve or artery injury are quite rare. There are some studies that have described developing uses for collagenase. The FDA recently approved the treatment of up to 2 joints concurrently using 2 doses of collagenase in either the same hand or the same finger. And other studies have evaluated non-FDA approved uses, including injection of the entire vial of collagenase, as well as use of the medication on nodules. So overall, I think collagenase is becoming kind of a workhorse in the Dupuytren's world. Patients can receive the medication while taking baby aspirin, but generally you need to stop any other anticoagulation. They should have some contracture so that manipulation is more effective. And again, I usually use 30 degrees of the MCP joint, 20 degrees of the PIP joint as my indications. But it's a clinic procedure. It's relatively convenient and effective, particularly at treating MCP joint contractures. And the rate of recurrence is lower than percutaneous needle fasciotomy. So the last treatment we'll talk about is limited fasciectomy, and this procedure occurs in the operating room and may take place through various incisions. Some of these incisions that you see on this hand we may use just to try and prevent or cover possible skin defects after we've extended the finger from its shortened position. And kind of on the right here you can see a cord after excision. So it said there's no old pilots, there are old pilots and there are bold pilots, but there are no old bold pilots. And I'd say this same thought exists for surgeons that address Dupuytren's disease. This is a relatively technically demanding surgery. I certainly find it engaging, and it requires patience and time. and the complications that occur can be significant. So it's just important to be aware of the potential there. That said, limited fasciectomy has demonstrated some of the best results with respect to correction of the MCP joint and PIP joint contractures. So Van Riesen demonstrated better short-term results in patients treated for MCP joint and PIP joint contractures using fasciectomy as opposed to percutaneous needle fasciotomy. And they also noted more durable results. And so when they evaluated for occurrence, which they define as an increase in greater than or equal to 20 degrees increase in passive extension deficit, 85% of patients treated with percutaneous needle fasciotomy experienced a recurrence at 5 years, compared with 21% treated with limited fasciectomy. Zhu noted improved outcomes with respect to the PIP joint when comparing limited fasciectomy to collagenase, and using matched cohorts described residual contractions of only 15 degrees of the PIP joint compared to 25 degrees after collagenase management. And lastly, Diaz looked at patterns of recurrence in patients after limited fasciectomy and contractures greater than 20 degrees, and noted that only 19% of patients experienced these after 5 years. He did note a pattern that PIP joints that demonstrated increasing contractures greater than 6 degrees at 6 months demonstrated more likelihood of progressing to a total contracture of greater than 20 degrees. So it's effective, however, there are risks, and these risks, while relatively rare, are important and significant. In one structured review of published studies, 1 in 25 patients experienced a nerve injury, 1 in 20 experienced chronic regional pain syndrome, and arterial injury was also noted. So I'd argue that these risks have driven a lot of physicians and surgeons to move towards collagenase as treatment. So overall, I'd say fasciectomy is an effective treatment for Dupuytren's contracture. The recurrent rate's low, and particularly for the PIP joint, limited fasciectomy provides the best results in terms of improving contracture and limiting recurrence. But that said, particularly in comparison to studies involving the percutaneous needle fasciotomy and collagenase, the studies for limited fasciectomy are relatively small, and so the data is not kind of rock solid quite yet. In terms of post-procedure management, I generally have 2 standard management protocols. After office procedures, I'll generally provide the patient with a 4x4 gauze and Coban wrap. They can take the dressing down the next day. Use the hand as tolerated. If they have a skin tear, I'll generally send them to hand therapy for assistance with management, and also for they can begin daily dressing changes with soap and water. As far as limited fasciectomy goes, I will generally place those patients in a splint for 5 to 7 days, and then have them referred to hand therapy for motion and edema control. I'll also have an extension brace fabricated, and while the data may not support that entirely, I think it helps give soft tissue rest to heal wounds, and help support the patient while it heals. So it's kind of a reasonable look at where we are and what we have to offer. So far, we've talked a fair amount about outcomes in terms of angles and degrees of contracture, as well as the likelihood of angular recurrence. And many of our studies have smaller numbers, and our ability to draw firmer conclusions remains limited. So why is that? And part of our current limitations sit around the outcomes that have been measured in the past. So in 2012, Worker looked at the definitions of what was considered a successful outcome, as well as the definitions of recurrence. And he noted that the definitions of success have shifted over time. So various studies have used outcomes such as clearance of disease, improvement in mobility of 5 years, less than 15% residual contracture with complete flexion, and percentage of improvement in extension in order to present their data. And it's difficult with these shifting grounds to come to strong conclusions, particularly with respect to surgical outcomes. And maybe, our overall outcomes aren't quite as good as we want, and so that's one of the reasons for these shifting definitions of success. But at the very least, these outcomes only address kind of one aspect of the disease and not entirely capture how Dupuytren's or its management affects our patients. For that, the next step may be to move forward with patient-reported outcomes, but these measures are relatively infrequently used. And of the measures that have been used thus far, not all have been validated for Dupuytren's disease. So again, Catherine Ball provided a good systematic review of these and noted that out of about 91 studies reporting on outcomes after Dupuytren's, only about 22 or less than a third reported outcomes as part of their results, patient-reported outcomes as part of their results, and fewer studies than that utilize these measures both before and after treatment. Of those patient-reported outcomes that have been used, the DASH and Quick DASH are probably the most common. And then the URAM, or the Unité Rheumatologique des Affections de la Main, I probably messed that up, sorry, is the other. And so we'll just touch on these briefly. The DASH and Quick DASH are, again, the most commonly used outcome scores. They contain 30 and 11 questions each, respectively, and have been shown to provide similar results. These scores do fall somewhat flat with respect to Dupuytren's, however. The pain component of these scores is often not applicable to Dupuytren's disease, and there's still yet to be determined a correlation between the amount of angular correction achieved after surgery and improvement in DASH scores. There's also a bit of a ceiling effect with respect to the DASH and Quick DASH, as many of these patients are quite functional even preoperatively. So combined, these issues have shown DASH and Quick DASH scores to be relatively poor measures with respect to patient outcomes after Dupuytren's. In contrast, the URAM, I'll leave it at that for now, was developed and validated specifically for the purpose of evaluating patient outcomes after Dupuytren's disease. It involves a score of 0 to 5, 0 being no difficulty and 5 being impossible for 9 questions. And while the scores were validated and evaluated for responsiveness, this process took place at a single center in France, and questions about more general applicability of these questions exist. So one study from the UK surveyed about 110 patients and noted of the 278 problems that they had, only about 55% were addressed, and the questions included on the URAM. So there's some questions about this scale as well. And so you can see some of these questions are maybe not applicable to what we all consider useful in our life. So in order to move forward and improve our understanding of patient outcomes, I'd say there's a few issues we should task ourselves with. I think a formal definition of success and recurrence should be agreed upon, and a responsive, valid, and more generalizable outcome measure would help. It'd be nice to develop a better understanding of the relationship between angular contracture and function for patients. And ultimately, I think a lot of this will require larger, well-designed comparison studies to permit us with more information to provide our patients. So as we leave today, I hope you take a few things with you. Progression of Dupuytren's is not inevitable. When contractures do occur, it's important to match the goals of the patient and their tolerance for complications with the proposed treatment plan. Each form of treatment has its strengths and weaknesses, whether they be convenience, low recurrence rate, or most tolerable potential complications. And lastly, there's relatively limited high-quality data, particularly addressing fasciectomies. I think that's a great opportunity for further studies. So thank you. If there are any questions.
So thank you for your summary. I have perhaps a comment and a question, and the comment is that patients that are treated with aponeurotomy, needle aponeurotomy, or Xiaflex with their recurrence, you didn't mention whether or not you just repeat those procedures, which I don't think we do. But I have found that in my practice, which is now a referral of failed things, that the territory, the surgery on a Dupuytren's patient who has had previous treatment is much more difficult than it was if you're the primary surgeon. The answer to that by people that are proponents for aponeurotomies and for Xiaflex state that it's just because of the quality of the disease and not because of the previous manipulation. Has anybody addressed that in the literature?
In terms of?
the difficulty, complications related to secondary surgery after
Yeah.
recurrence.
So there's a recent study that looked at revision surgery after collagenase. It seemed to be a little bit more qualitative in nature, but basically kind of described what the surgeon saw at the time of operation and kind of the length of the operation, I believe. Having performed a revision surgery after collagenase, I can only give you my experience, but generally those patients have kind of a lot of fat in that area around the cord itself, which then becomes more difficult to find the nerves and protect them. Obviously, there's scar tissue as well, and so it just takes a lot more time. You know, your revision surgery is going to be more extensive. You have to spend more time finding the nerves in an area of normal tissue, and then kind of tracing those and constantly moving back and forth between the cord and the nerve, and just being aware of kind of where your anatomy is. So, you know, obviously it takes a lot longer. The results are probably not as good, and I have to look back at that study to give you a great answer on the numbers, but it can be done. It's difficult, which again, it goes back to the reasons why we wait to try and address these when the contractures become significant.
Yeah, thanks for your great talk. So we know that Dupuytren's has a really substantial genetic component. And so I was wondering if you think that there's a benefit to doing or developing genetic tests that can help inform your sort of clinical decision-making beyond just sort of family history.
So I think that's a great point. There's lots of research being done to identify specific genes, and there hasn't been any consensus as to a single gene or even a handful of genes that can reliably be isolated as contributing to disease. So with the knowledge that we have right now, I don't believe that that's possible, but if we were able to better determine with genetic testing, that would be something to certainly consider down the line. I think the goal is, as we continue to learn more about Dupuytren's disease, to be able to isolate genetically where it's coming from and what environmental triggers may be contributing, so that we can intervene at that point. And really, if we can better determine the biochemical nature of how this process is occurring and intervene, I think that would be kind of the holy grail of treatment to intervene medically.
I have a question, kind of random. Is this related to the lederhosens or whatever in the foot?
Yeah. So
foot
kind
can
of
get
the Dupuytren's diathesis that we see, we'll see in relation to, you know, often patients may present with contractures of the palm, which we consider Dupuytren's lederhose disease, which would be contractures of the plantar fascia of the foot, and potentially Peyronie's disease, which can involve the penis.
And then I feel like the comment that you made about this being spread by Vikings, like I feel like, have you guys noticed that it's more common in this part of the country as a result? Or I feel like I get, like frozen shoulder in my mind is kind of in this same spectrum, and I feel like we see a lot of it in patients. This is just anecdotal in me, like checking out their name, but it's like Larsons and the Ericksons that seem to have frozen shoulder more commonly. But maybe I'm just making that up.
Yeah, it's a good point. I mean, we have a larger Scandinavian population here, but you know, having only worked here, it's hard for me to compare different regions. You know, so I'd have a hard time saying.
Great talk and overview, Brett and Nick. So you talked about some of the less invasive options, fasciotomy, non-operative, and also collagenase. Have your indications changed as far as your surgical indications at 30, MP, and PIP? Also, Dr. Hannon talked about the tougher revision surgery and tougher revision treatments. How do you kind of balance out with your patients when you're seeing these patients coming in with 23 contractures saying, hey, it's getting in the way, I want something done? Do you try and wait it out? Do you try and talk them into waiting until it's more disabling?
Yeah, I generally do. You know, I want everybody to leave happy, but at the same time, I also want them to leave with the understanding that, you know, if we go in and try and treat this, that there is a likelihood that they will recur given enough time. And so some of that depends on age, I guess. You know, if we look at that study that that Pest did, and patients 55 years or older end up recurring more or less frequently than younger patients. You I may have a little bit of a lower threshold for kind of an 80-year-old patient that wanders in who's just like driven nuts by the fact he has trouble getting his hand in his pocket or has trouble shaking somebody's hand, as opposed to a 45-year-old, who, if I were to operate on that patient, they'd probably be more likely to recur. And so, I think everybody has to be treated individually. And some of that also, again, matches what we have to do to get the contracture better, versus the kind of the invasiveness that's required. Luckily at the VA, I'll say that for collagenase at least, there are pretty specific guidelines. So they do make you say that the patient has a contracture of 30 degrees at the MCB joint or 20 degrees at the PIP joint when you go to order that medication. And so they've kind of restricted the use somewhat. But I try to carry that forward to my other sites of practice as well. I think it's not an unreasonable